Welcome to Concussion Talk Podcast. This is episode 45, and I'm Nick Mercer, and I'm talking to Scott Anderson, the CCO, the Chief Clinical Officer of SyncThink in Palo Alto, California. And they've developed a remarkable technology, iSync device, that Scott will now talk about that device and what it does and how it uses eye tracking to help with the concussion, not diagnose, but the recognition of that the eye, that brain impairment for the eyes show. Okay, thank you, Scott.
Yeah, so thanks for having me, Nick. I appreciate it, and happy to talk about iSync and our technology. It's been a long time in the making. It's really developed its roots over a decade ago in concert with the Department of Defense in the United States. And the Department of Defense really funded a lot of the early work to develop the technology and to pioneer much of the research around eye tracking as a biological indicator of brain performance and readiness. Really what the military was interested in looking at was, are soldiers feel deployable and ready to perform the duties that they ask them to do? On the heels of basic training, are they subjected to many things in training that may compromise their ability to think on their feet and react and avoid injury, those types of things? And then, in addition to that, is there, the benefit of some type of mobile technology that can be used in the field that can justify the removal of soldiers when they've been exposed to, RPE rounds or ammunition rounds, things like that. Those things that may have, put a soldier at risk for a traumatic brain injury. So, this was based on our technology really was developed based on this idea that many soldiers were coming home with issues that have been previously unreported, and they wanted high fidelity, objective information that could help make the decision for them about whether or not soldiers are optimized for battle. And we see a lot of carryover in that in the market for regular folks, regular people who have experienced a traumatic brain injury, who have been subject to head injuries that require a more sophisticated approach to how they're evaluated. And that's essentially what our system does. So we take a modified virtual reality goggle set that's equipped with high fidelity research-grade optical lenses, cameras that work in the infrared to detect your eye position, and we measure your attention by providing a stimulus in the system that you have to pay attention to. And over this years of study, we found there's certain indicators of high performance and indicators of impairment that are specific to brain function that are able to be detected in eye movements. And so our cameras sample at a really high rate and are able to capture this eye movement while you're performing various tasks. And this gives us a rapid indication of orientation, how well you orient to the world around you, how well you are able to process information, visual information, so that you can either verbally or motorically respond quickly, and how well you're able to predict the things that are happening in your environment. And if you look at sports and you look at daily life, we're constantly having to predict the world that's around us and having to respond to things that are happening in our environment. That's how we become synchronized with the world around us and how we orient to time and space. And so that's what our system does. We found that in concussion specifically, that these visual orientation deficits are extremely common in patients, and there are it's a strong indicator of poor performance, and that there's a need for remediation in these situations. And so our system is developed to identify this with a series of 60-second tests that can be done really quickly and simply and non-invasively for patients. And then we provide some remediation strategies to resolve the condition, to help resolve the condition. So providing some early stage rehabilitation tools and some training environments, all in the virtual reality goggles that patients can use to improve their visual orientation quality, so that they can recover from their injury and they can learn to orient better so that they can avoid future exposure to injuries. So that's in a nutshell essentially what our technology does and how we've been utilizing it in the field.
Oh, that's impressive. So I know Dr. Jagar
Yep.
is the author of the study, but I just read the abstract actually of the concussion subtypes that they found. It's the recent one, the ones from August
Yep.
19th, I believe. So that I was sent. So could you explain what do you know? Can you
Sure.
explain what the five there are five concussion
Yep.
subtypes, and you focus on eye movement, right?
Yes.
Your
So
technology.
yeah, so this is a massive, bombshell to the concussion community in terms of, a really positive step forward in terms of how we are understanding concussion today. The traditional management of this injury has focused on the subjective reporting of symptoms and progressing patients based on how they feel and not by any objective standards. And the reason why that's the case is because you can x-ray somebody's head or give them a CT scan, but it's not going to show any problem in cases of concussion. And so the clinicians that are treating patients are left with having the patient guide them through the recovery process and letting the patient dictate how they recover. The significance of this paper that you're referring to, which is really the first evidence-based guidelines for concussion management, utilizing a classification system, which is let's look at what are the prevalent indicators of concussion are, the most prevalent and common deficits that we see in concussion, and let's focus on how prevalent they are and try to incorporate these into how we clinically manage concussion. And so the body of evidence has spoken, and many of these clinicians, these experts in the field of concussion research and clinical care, have come together to categorize these into concussion subtypes and to classify them as subcategories that need to be measured and need to be properly evaluated. And really, the whole point of this is that the emphasis needs to be on targeting specific therapies towards these dysfunctions so that they will resolve. And as you probably know, the status quo for how this has been done previously has been to listen to the patient's symptoms, make the diagnosis, and tell them to go sit in a dark room until they feel better. And when they feel better, then they miraculously have recovered and they should be fine. And that's just not the way that we manage conditions in medicine. And so I don't understand, many of us don't understand why that's been the status quo for a long time. And the reality of the situation is we haven't had a body of evidence to dictate how a standard of care for this injury. And so as a result of that, you have wide-ranging variability in how the diagnosis is made by clinicians, and you don't have an evidence-based guideline to drive the standard of care. And so that's really what the emphasis on this document, this publication really emphasizes, that you need to look at these five symptoms. Number one, the vestibular system, highly, highly common in kids and adults, of being dysfunctional after concussion. Number two, the visual system, which is something that is also very common, more common in children, but certainly common in adults as well. Number three, headache and post-traumatic migraine. Those are also the most common types of conditions that people report after concussion, is headache or migraine. The next one is anxiety and mood disorders. This is typically in cases of prolonged recovery where people are feeling anxious and depressed because they've been removed from their life and they've been, essentially told not to do anything. And so they develop these secondary comorbid factors that affect their lifestyle. It's not necessarily something that's truly prevalent or more prevalent than the other conditions I previously referenced, at the time of the injury. And, beyond that, we look at other factors such as sleep disorders, involvement of the cervical spine. Those are all confounders to the recovery process, and those are things that we consider to be, elements of the clinical evaluation that must occur in order to clearly identify that a concussion has occurred and that a certain dysfunction has resulted that needs some type of targeted therapy. And so a specific type of physical therapy prescription and plan so that the patient can improve. And I think that's really what we are focused on in the community, is getting people to understand that this should be part of your clinical evaluation, that patients should demand that these systems be evaluated properly and objectively, and that they have either exposure to the therapy that's going to resolve these conditions, or that they are referred to a specialist who can do those things for them. Because what we know is that the sooner that you intervene, the quicker the condition will resolve with the appropriate therapy. And if they're told to do nothing but sit at home and wait for their symptoms to improve, they're not necessarily addressing the dysfunction that's occurred as a result of the injury.
Right. Okay. Well, actually, I know you work for Stanford medical. You're medical director for Stanford sports
That's correct.
medical
Yeah,
director.
I ran the sports medicine program. Yeah,
And
for a long time.
and the Pac-12, you're on the board of the Pac-12, which is the NCAA division on the West Coast, or NCAA division on the West Coast, and Division One. Pac-12 Sports
Yep.
Medicine.
Yeah, the Pac-12 is a athletic conference that features 12 of the primary schools that Stanford competes against, and we have a very strong, robust sports medicine infrastructure that compromises all the leadership and all the medical professionals from not only from the conference itself, but also from all the institutions. And so we have been working for 7-8 years now. And I was the original chair of this group to really pioneer multidisciplinary research in the student athlete population on areas like concussion. There's other categories as well that we focused on, but really the emphasis has been working on trying to learn more about the natural history of head injury and to design concussion studies around our patient population, which is the young student athletes, collegiate athletes.
And before I ask you about double vision, which is a particular interest to me, the Stanford and the Pac-12 has adopted iSync device or just Pac-12?
Yep.
And Stanford?
Yep.
Well, I guess as part of the Pac-12 they have to. So who actually uses the device, and how is this administered? You're talking about therapists. I mean, physiotherapists use this in clinics.
The sports medicine doctors and the physical therapists and athletic trainers all work together to utilize the system, both at different time points in the event of an injury. And so you'll see the technology utilized on the sideline during sporting events. You see it will be used in the locker room, after sporting events. It will be used in the recovery, on a kind of daily basis type of thing, or every other day type of thing until the patient returns to normal. All of that will be is part of a standardized protocol that the Pac-12 is operating through the University of Colorado, which is acting as a coordinating center for this CAP project, this care-affiliated project that the Pac-12 is running.
Okay. That's definitely interesting. So our physiotherapists also, I know, but it's performance as well. It's sort of performance use as well. But in terms of concussion therapy and concussion, well, I hate to say diagnosis. I mean, make it known that this is not a concussion diagnostic tool. It is a tool. It is a device that hopes to highlight and objectify certain parts of one aspect of concussion. And
so our technology focus on the vestibular and the ocular components of the concussion subtypes. So, there is no such thing currently today as a diagnostic device, a green light or a red light for concussion. And the reason why is because there's no evidence-based definition for concussion. And so that's the reason why we are moving towards a subtype classification, which you see in other disease states, very common in other disease states too as well. And so I think we're many years, and it's so far off in the distance of having a diagnostic for concussion that this is going to be the future of how concussions are managed. And we look at the most prevalent types of dysfunctions that are common, which are the vestibular disorders and the visual deficits that are seen. So we rapidly measure those, identify those, rule those in as the subtypes that are performing suboptimally and are in need of rehabilitation. And that the point of that is, one, we want to establish a logical and practical workflow for clinicians so that they can, essentially with objective information, they can make decisions to rule in and rule out the types of dysfunctions that they're seeing in their patient population, and two, that they can orchestrate and identify the appropriate type of treatment that's necessary for these conditions. And what I mean by that is that there are specialists that are need to be focused on these areas to help the patient recover, that these patients need to see. If someone has a visual problem, they should be seeing a neuro-optometrist. If someone has a vestibular problem, they should be seeing a vestibular therapist. If they have a migraine, they should be seeing a headache specialist, a headache and migraine clinic specialist. So it's about identifying the type of disorders that are occurring in this patient and getting them to the appropriate specialist so they can get the actual treatment and therapy to correct their problem. So that's the important thing, and that's what's not happening.
Yeah.
And so you're seeing people who are carrying these dysfunctions with them, and it's leading to secondary comorbid issues that are affecting their lifestyle, and they're not recovering from those things because they're not getting to the right people that's helping them recover from those things. And what we've seen is the further away that you get from the time of the injury that you're living with this disorder, the harder it is to rehabilitate and the harder it is to get you back to normal. And so you're susceptible to other types of issues and pathologies and diseases and things like that that are risk factors, become heightened risk factors as a result. So the key point is, can we rapidly identify somebody at the time of injury about what is most commonly occurring with them? And by the way, these all can overlap. You can have somebody that has a combination of these types of subtypes that needs multiple types of therapeutic interventions for. It's not just one or another. It can be, someone can have a vestibular problem, a visual problem, and a neck problem all at once. Someone can have a headache and a depressive disorder and a visual problem at the same time. Those things can overlap, and that's where the science is going after this. Is that really looking at the prevalence of clustering these subtypes and seeing which ones are most commonly occurring together with each other, so that these clinicians are aware of the types of therapy that need to be provided to fix their issues. One point I want to make about sleep too is I think it's very important, is that many patients who suffer concussion have associated sleep disturbance, and this happens in the acute phase. And if their sleep is not their sleep issue is not identified and addressed immediately, it will linger and it will delay the prognosis. And so that's one thing I really love about our technology, is that we can also identify differentiated eye movements that's separate from some of the impairments that we see, that tells us that the patient is sleep deprived. So we know that if the patient is not recovering, we can look at their sleep deprivation scores and see that their disturbance is still affecting the way that they're recovering, and that we need to get them the appropriate remediation for fixing their sleep problem so that it can expedite the recovery process. That's something that's extremely overlooked in the population, the injury population in concussion, is that many of these folks, especially people who have been living with the after effects of concussion without the appropriate treatment, these people are waking up multiple times throughout the night. They're having trouble falling asleep. They're getting 4 to 5 hours a night of sleep. It's extremely common for people to have these types of issues carry over and become impediments to their healthy lifestyle after the fact. Yeah. So that's another piece I wanted to mention too.
Exactly. Then they can't get enough rest for physiotherapy or occupational therapy, whatever, or even or psychology or whatever. But actually, you brought up your point to because I'm 16 years since my severe brain injury and have concussion, had a coma. But I also wanted to mention that you said objective measures. So I want to ask you about because when I hear objective measures, I think of numbers, stats, and then just measures basically. So what sort of data does your device give to physical therapists, and doctors to know that someone is improving or not improving?
Sure. So what we measure is variance. So variance is a key indicator of performance, in the form of a standard deviation. So how many standard deviations are you away from normal performance? What is the variance between what we should expect to see in the normal population versus the impaired population? And so what we do is we provide a stimulus in the goggles that you follow with your eyes, or that you fixate on as you're in motion, depending on the system that we're measuring.
I read there was a circular motion. Was that just?
Yeah, that's one of them. Yep.
Okay.
Yep. So we can do circular smooth pursuit where you have a target that's going around in a circle and we're measuring your attention, how well you can follow it. And our cameras that are working in the background in infrared, which you don't see, are taking snapshots of your eye position all along the path of the motion of the test. So in a circular smooth pursuit test, for example, that's something that we're measuring. And what we're calculating is the difference between where your eye is landing and where the target is. And the difference between that gives us the variance and tells us how much error there is between where your brain is directing your eye and where your eye should be. And so the lower the variance, the better the performance. The higher the variance, the poor performance you have, and the more that is an indication of either something has affected your performance, and that can be an injury, a head injury. It can be sleep deprivation. It can be drugs and alcohol. It can be stimulants. There's many things that can affect the quality of the performance of this. And so we notice that there are unique signatures in each of these performance. In each of the tests that we capture, and we can essentially differentiate between them and say, oh, this is an indicator of performance of somebody who's sleep deprived. Oh, this is somebody who has a visual impairment from concussion. Oh, this is a person with ADHD. There are unique biological signatures in each of those movements of the eyes that really tell us information about the status of the brain.
That's very interesting thing about the variance of the eye movement, because as I mentioned, as you know, I mentioned to you before, that I had both double vision. I've had double vision since my brain injury 16 years ago. So
yep.
Again, that was long, as you said, a long time since my accident. So it's hard to rehabilitate and get therapy for this. But so I have double vision in my eyes. I just don't like. I mean, I have binoculars. Binocular vision. So if I close one eye, that's fine. It's singlet. But my right side I'm right side eye dominant, so I see better on it. But I do see right now. I'm looking at my stove, for example, and I see the pillar of one of in my apartment coming down, and I see that also to the side. So how would variance show up in someone who with varying degrees of diplopia, double vision?
Yeah, so that's one of the things we measure is what we call that binocular coordination.
Yeah.
So how well is the brain able to team the eye movements together? Right. And so in our reports, you see the different performances between the two eyes. And so you can see which one is the dominant eye, which one is the eye that's not, that has the attention problem. If you see normal performance in one eye and poor performance in another, the recommendation in those situations many times would be, we need to focus on training the other eye so that it can team with the other eye, with the dominant eye. So the dominant eye may be fine and may not have a problem. The other eye may be lagging behind or maybe doing something different. This is something that we see in development all the time in children, is because they're learning to develop their attention. And, attention is a key driver in how we learn and how we cognitively
retain
do the things that we need to do on a daily basis. So in children, what we see is as they're developing their attention and they're exposed to a myriad of things that are happening in the visual field, they're honing their attention over time. But it doesn't become optimized until about puberty, and prior to that, we see that the two eyes are learning to team together, and so they may be, doing two different things. And in certain instances, for example, with reading, they may have one eye that's on one line of the paragraph, and the other eye is below it on another eye. And what happens is the brain gets an error signal, and they can't maintain their focus. And so you see a lot of times kids turn their head away, and they can't maintain their gaze position for a long period of time because they're looking at two different things, and the brain can't process them both at the same time, and it creates an error. So being able to train these eyes to do the same thing is extremely important and a critical component of vision training or vision therapy that neurooptometrists provide. And sometimes corrective lenses help with that if diplopia is an issue. There's different types of tests that neurooptometrists do to look at, contrast sensitivity or depth perception or other factors that may be disrupted that also can be corrected with prisms and different corrective lenses, those types of things. So it's all about having a thorough evaluation, learning about where the deficit lies, and then being able to remediate it either with training or some type of external corrective device.
Right. Wow. I listened to you talk also on Answer the Bell podcast, specifying Bell from ESPN, and you're talking about normative data. So I asked you to talk about normative data. So you actually talk about how if you were saying the kids learning in their eyes before puberty, they're learning how to their eyes learn to coordinate. So your measurements, but I know you have a bunch of athletes like trained athletes to use iSync for performance measures.
Yep.
But for kids, so how would you have normative data for kids as well, but how does that differ from adults versus kids? You're looking at iSync knowledge of kids as opposed to above, say, 13, like I said.
Yeah, so we have normative data on ages 7 to 70. We look at, and we published on this too as well. We look at the curve of eye tracking performance across the lifespan. It kind of looks like a hockey stick, so to speak, something you'd be familiar with, a hockey stick being where you're at. We see high variance in kids as they're developing their attention. It levels out in puberty till about 40 or 50 years old, and then it starts to decline again as you get older. And what we see is that you should expect to see normal population from teenage years to the start of middle age. And if you don't see it in that population, then there is a potential that those individuals can improve with training. The people that are outside of that fall outside of that bell curve, you can train them to expedite their ability to improve their attention over time. But we see, differing results based on their age and based on their cognitive function and other factors, that affect how quickly they can improve. Now, when we looked at athletes outperform the norms drastically, and we think this is because they have had repeated exposure to high velocity visual information, for years and years and years, and so they've learned to pay attention to things that are happening rapidly all around them all the time, including the speed and trajectory of balls for athletes that are playing ball sports. And so we should expect to see really high performance in those athletes. And so it's a very obvious situation when we see an athlete on the field who we think may have sustained a head injury. We evaluate them and we see that they have abnormal or really high variance in their scores. We know that we should expect to see very low variance, and when they don't and they're 2 standard deviations away, we know that that's abnormal, right? So the key is, can we get them back to that point with training, with therapy, and in those populations we can. We do that very well. The other thing that I'm very interested in is sort of proactively improving visual performance in the non-impaired population. So taking people who are, perhaps, performing at the level of the normal population, but they need to be higher performing based on their sport. So, for example, if we looked at baseball players, we know that baseball players are the best performing individuals that we've ever seen in our system. They're really high performing, very low variance across the board. They've had decades of high velocity information, going back and forth across their visual field for years and years, right? Tennis players as well. And so, but you'll see a percentage of these athletes who don't look like their teammates. They look like you and me, and so it's a matter of selecting those individuals and proactively training them to improve their dynamic vision training or their dynamic vision skill, so that they can have better attention when they're playing their sport, so they can optimize it essentially for their sport. And so that's something that I'm very interested in, and something that I think can be done with many athletes. It's an overlooked skill, in my opinion, an overlooked performance skill that can be screened and can be improved, for sport purposes.
I could talk about that. I could ask you questions all day about this technology. It's fascinating stuff. But back to concussion for the last question.
Sure.
So you say you obviously have measures of variance for for eye movement for concussed individuals that you look at? Is there a number that you say, okay, this person's eyes are, or just depends on your note data? If you don't have say you don't have a baseline for say Jimmy or Sarah, who's like 25 years old and they think they may have a concussion, and you measure them, but you have no baseline previous data. So how would you say?
So we look at it depends on the test because we have different variance measures against the norms that we should expect to see. But just a rule of thumb, I would say that typically if anybody has a standard deviation, it's greater than 1. Like we expect to see some variance in all the population because nobody's perfect. But if someone is a full standard deviation away from the normal population, then that's abnormal in our opinion. So that's how I would say there's as a rule of thumb that would be the case, but for each of our tests it's slightly different. So
that'd be an average of all your tests together, like one standard deviation average away, not one test away, not one standard deviation, one test.
Yep.
So have you had many have you been to obviously Pac-12 Medical Sports Medicine Committee? Have you seen any athletes who've in acute situations or far out from their concussion? Have you seen athletes who display obvious
all the time
parents?
All the time. Yeah.
And
we captured just last year alone with all of our kind of partners in the field and the people who are using iSync, I think we saw over 2,000 concussions.
Wow. Did all of them but there was the iSync used in well, I was using all those, but was an obvious variance for the eye? Was there vestibular and
ocular? Yeah, I mean, there's a certain percentage of people who are falling in different categories as far as those are concerned, in terms of the dysfunctions that we pick up. But in general, I would say that there's a wide range of evaluations that have been done on various populations, and our system has picked up the indicator for these subtypes that we're trying to classify. We're not making the diagnosis of concussion. We're not saying it's a tool that's going to make a diagnosis because nobody knows what that is. So what we're saying is, look, these visual and vestibular issues are very prevalent in this type of injury, and you should be evaluating these as part of your clinical approach. And if you're not, you should be, because the evidence is telling you that these are the most common things that we find.
Right. Okay. So what's the next for SyncThink and the iSync device and
I think the next thing for us is we're really focused on the performance market and continuing to develop clinical partnerships. I think you're going to see some really interesting things in 2020 from us in terms of how we deliver this to the market with respect to the hardware that we use. So there's some really interesting and fascinating capabilities that we'll be enabling in 2020, and we're excited to launch those. And I think it's going to be well received by the clinical community.
It certainly sounds like. I mean, it's incredible. It's incredible technology. I just love to see how it works. And so how can people who are listening to this podcast, how can they find more information about SyncThink?
They can go to our website, www.syncthink.com. They can follow us on social media, SyncThink Inc., on Twitter or Facebook or Instagram. We routinely provide updates on our company and our research and the work of our partners there. So that's where you can find all our information.
Well, thank you so much, Scott. This is like I said, a fascinating talk, and I love to just talk forever about this, but you have work to do. So, but thank you so much. This is a great conversation, and I think I definitely think the technology is useful for concussion. To notice those vestibular and ocular subtypes of concussion.
Yeah, thanks, Nick. I appreciate being on, and it's great to talk to you.
Thanks. Thanks again to Scott. I didn't like how he came across at the beginning of the episode, but thank you for sticking with me. And please visit my website at www.concussiontalk.com, and please visit iSync So syncthink.com to find out what they're up to and follow them on social media. Follow me on social media as well at Concussion Talk. Thank you all again, and I hope you listen again next time. As always, music at the beginning of this podcast is by Ben Sound. www.bensound.com.